All right. Well, hello, everyone. This is Dr. Isabelle Amigues from On Average MD, your friendly rheumatologist. And today it's the part 3 of our series on Sjogren. And we are learning how to treat Sjogren. And really remember, everyone is very different. And so it's not medical advice, as you know, like we're in America after all. So disclaimer, but really the goal of this is really to kind of give you a sense of how we think as rheumatologists when it comes to Sjogren, so which is also called Zika, or like dry eyes, dry mouth, autoimmune syndrome. So again, if you are interested in learning more about Sjogren, how it presents, how we diagnose it, don't hesitate to go to the Rheumatology 101 YouTube video. You could actually join so that you're never missing a live. And then that way you can learn more about this. So I'm going to give a little bit of cases like the last time we did, just because it relates more to what we see in clinical practice. And I think we all love stories, right? So I'm going to start with this patient that I saw a while ago now, in her 50s, a wonderful professor that had dry eyes of the mouth, dry eyes of the eyes, but really the thing that she was bothered the most by was severe fatigue. And she also had a little bit of joint pain, and as you know, joint pain can be associated with Sjogren. And so basically, because she had a little bit of joint pain, we decided to start her on Plaquenil, so hydroxychloroquine, which, as I've mentioned many times before, is not immunosuppressive, but restores the immune balance in her system. Usually we say that Plaquenil takes up to 4 months to work. And I think within a month, she had no more fatigue. It took more time for her joint pain to go away, but she had no more fatigue. I'm sharing this. This is not evidence-based because it's really just one case, but it's the fact that I'm just giving you some example of how we think, right? And in the case of this Plaquenil, that works really well for fatigue. We don't really have much studies that are showing that, but in some patients it does work. And again, the reason we started it was because she had some joint pain. Okay, so that's one case. Another case, severe joint pain, inflammatory. So remember, worse in the morning, associated with morning stiffness, and associated sometimes with swelling, and a little bit of dry eyes, dry mouth. This patient, we started something for the dry eyes, the dry mouth. I'll talk about this after. And we also gave her Plaquenil or hydroxychloroquine, and she has done superbly with it. So no more joint pain. So that's really good. Another type of patient is someone that would come with a ton, like dry eyes, dry mouth, ton of pain all over the body. And if you touch her, she has just like pain everywhere, pain to the touch when you would not expect that much pain, just touching, hugging someone, it causes pain. For this patient, we thought that this was more like small fibrous neuropathy or, which looks like fibromyalgia, or fibromyalgia looks like small fibrous neuropathy. And so for her, actually, we treated the fibromyalgia symptoms. Again, I will go about this in a couple. Finally, a patient with shortness of breath, Sjogren. We knew she had Sjogren. She had shortness of breath, and we found that she had lung involvement of her Sjogren. For this patient, we actually went to a much higher drug that immunosuppressed. Again, she had shortness of breath. This is very important. Remember, you may have a rheumatologist that tells you, oh, you have lung involvement, or oh, you have joint involvement, or you have nerve involvement. But it's also the degree of involvement you have that makes us decide how we treat you. So that's really important, right? Because the goal here is not to tell you, oh, this is how we're treating you. It's more to give you how we think. Okay, so in this case, we give Rituxan, and she's done very well. Some patients with interstitial lung disease will get azathioprine, which is an immunosuppressive agent, and so on. But I think, so now I want to kind of generalize this. In Sjogren in general, you've heard me maybe before say how important it is for us to achieve remission when you have a rheumatologic condition. And I really do believe that we always aim for remission. When it comes to Sjogren, as you remember, the issue with Sjogren is that the inflammation leads to scarring of the tissue. And it's much harder to treat the scarring of the tissue with immunosuppressive agent. It actually doesn't really work. And so what we are thinking when we're addressing a patient in rheumatology, right, that has a Sjogren, is how do I help their symptoms and how do I prevent further damage? And can I possibly reverse the inflammatory process that they have so that we stop this process and that they can have a fully functional life? In Sjogren, there is two aspects of how we're going to take care of patients. The first aspect is, does this patient need immunosuppression? So earlier, when we were talking about those little cases here, we saw that you have the possibility of just very mild symptoms, such as just joint pain, inflammatory arthritis, or you can go all the way to something very severe with lung involvement, and that causes you to have shortness of breath and so on. And so, of course, you will tell me, right, like it makes absolutely sense that we're not giving the same amount of immunosuppression in those two types of patients. There are some that are going to need just immunomodulation, such as Plaquenil, because again, Plaquenil does not immunosuppress your system. It really just helps you put it back in balance. So we would do Plaquenil or hydroxychloroquine. It's exactly the same thing. Or if they have severe, so let's say they have severe neuropathy, so nerve damage, or they have a severe lung disease, then we're not just going to go and give something very mild. We're actually give something much stronger, such as Rituxan. And the reason I love Rituxan is that it acts on the B cell. And as you may or may not recall from the first part of this Sjogren talk, is that Sjogren is very much a B cell issue, right? It's the B cell that are making all of those antibodies, and that are basically at the core of the issue in Sjogren. And so Rituxan works really well. And then again, I think I had told you that one of the most severe complications of Sjogren is to develop lymphoma, which is a certain type of cancer, and that Rituxan actually is a treatment against lymphoma. It's not a chemotherapeutic drug, so it's not chemo per se, it's a biologic drug. And some people will be like, oh my gosh, you want to give me Rituxan? This is so scary. It's used in lymphoma. No. And I'm like, no, it's very targeted. We act on the B cell only. We act on a specific receptor. So it's very targeted. And I think this is the future of medicine, where we're going to target the exact issue associated with all of our conditions, right? Okay, so the immunosuppressive part or immunomodulatory part, so that's the first one. And then the second part is the symptom. So the first one is the dry eyes, dry mouth. We can actually help with that. We can give some specific type of eye drops. We can also refer you to an eye doc, and they can put some plugs so that instead of losing the tears, which we all lose tears, but if you have not much to lose from, you want to keep them and retain them in at the level of the eye. And so then to do this, what we can do is to plug to stop the tears from getting away. It can be a little bit annoying if you have both sides, so that the upper and the lower that are plugged in, because then you may actually have tears on the sides. It can be a little bit too much. So working with your ophthalmologist can really help get the proper one. And usually they stay. It's very, very small, and it usually stays. So that can be very helpful. And then for dry mouth, we can give you cevimeline or atropine, and that can help. I would say one other thing that everyone can do is you can actually use sugar-free candies. And I remember a teacher when I was a kid who would say, oh, chewing gums are only here to lose saliva. And it's really funny now as a rheumatologist to think that no, actually it helps keep saliva. We're not losing saliva, you're keeping the saliva. So that's like chewing actually stimulates the saliva, and it's really not a bad thing. Some people recommend to massage your parotid, massage the salivary gland, the submandibular salivary gland. So you can massage that. And the same thing with the eyes, by the way. I've got some patients where they do that, like it's a ritual in their morning, and they do that and they love it. So definitely something that you can do, and why not put it in your morning anyway? You can just even like send some love or healing thoughts, and why not? That does seem to work in definitely a significant proportion of patients. If you were to have severe fatigue, there's no really study on Plaquenil and fatigue in Sjogren, but I have to say I've seen cases where it works. So for me, I sometimes at least try. It doesn't mean you're going to be on it forever, but like I think it's worth a try, because if we can improve your quality of life by decreasing the fatigue, it's worth it. So Plaquenil is a possible option. And then honestly, exercising. It sounds odd, but exercising actually gives you energy. It stimulates your immune system, and it helps you heal. And so that can really help. Helping with sleep, having a sleep schedule so that you don't have as many insomnia, for example, and you actually sleep. Make sure that you don't watch, this is really hard, but don't watch screen, including your phone, iPad, TV, at least 2 hours before you sleep. So, maybe like this is the time for you to get a better, get back at reading, which personally I find really cool to read before I sleep. I love it. And when I don't do it, usually I don't sleep as well. So that's like something definitely that helps. And then for the fibromyalgia component or the small fibers neuropathy, we can actually give you Cymbalta, which works wonders when it comes to small fibers neuropathy and fibromyalgia, and is actually an antidepressant, but really works just for the small fibers neuropathy. I have patients who have absolutely no depression, and they have this small fibers neuropathy or fibromyalgia, and you put them on the Cymbalta, and they have no more symptoms of small fibers neuropathy. So it's really, really cool. I mean, just remember, depression is a neurologic issue, and so we're just using one of those drugs for our benefit. In general, I recommend everyone that has Sjogren to see their dentist at least twice a year, if not every 4 months, because you really want to have a good dental hygiene so that there's no gum recession that you can prevent. So that's really important. We do ask to see an ophthalmologist once a year. And we do ophthalmologist. I don't know what I said, but ophthalmologist. So eye exam once a year. And then your rheumatologist at least once a year with a physical exam. This is one where it's important to see the patient so that we can touch and see if you have any lymph nodes that have appeared. And then we also do blood work, make sure that everything is looking good and under control. And then of course, if you have any sort of symptoms like lung disease or neuropathy, that's more than just the small fibers neuropathy, but you actually have or maybe you have some skin changes with vasculitis or inflammation of the vessel and so on. Those are the time where you probably want to do more, and you want to see your doctors a lot more. Okay, well, the good news here is that we have treatments that it keeps, I think Sjogren is the next big condition that we're going to have more studies in, and we're starting to see that, because there's a lot of patients who have it. And now that, rheumatoid arthritis is taken care of, and all of those other more obvious condition, in the sense of it's not just dry eyes, dry mouth, and fatigue, because a lot of patients who have Sjogren just have that, and they can continue to live. But if you have joint pain and you cannot continue to live, that's, a bigger issue, I would say. I would argue that it is another issue, is just the quality of life. But anyway, so we are seeing more and more studies. I think we can be very hopeful in what's happening in the future. And I really hope this conversation really helped you understand how we think when we're looking at Sjogren and how to treat it. I will see you next week, this time at 11 at the proper, the same time, 11 Mountain Time. And until then, I wish you a really good week.